Hello, my dear students and colleagues in critical care medicine. Let's discuss two interesting MCQs in this part of mechanical ventilation, which will be very useful for NEET SSC aspirants in critical care medicine. A 35-year-old man has been admitted in ICU for ARDS secondary to recent COVID-19 critical illness. He has been intubated for 1 week. The nurse informs to tell you that his oxygen saturation dropped to 70% and his systolic blood pressure also dropped into the 70s. He's febrile. She has already started to give him a 1 liter bolus of normal saline. On physical examination, he was noted to be diaphoretic and tachypneic. Crepitus was noted on palpation of the right side of his neck and anterior chest wall. On the ventilator, the peak airway pressure is markedly elevated at 60 centimeter of water. A chest radiograph is ordered, which is shown over here. So what is the cause of his rapid drop in blood pressure? A, obstructive shock, B, cardiogenic shock, C, septic shock, or D, hypovolemic shock. If you look at chest x-ray closely, do you find something abnormal on the right side of the lung field? Isn't it more enlarged? Doesn't appear to more translucent with widened intercostal space compared to the left side? If you look at it more closely, you would be able to appreciate the loss of bronchovascular markings seen in the normal lung. If you look at the stem of the MCQ, there is high peak pressure of 60 centimeter of water. And also there is crepitus on palpation of the right side of his neck. So probably there is surgical emphysema. And this is probably related to the pneumothorax. And this pneumothorax is causing this high peak pressure, which can occur in that situation due to lung collapse. And we know that it is quite rare. In about 0.3% to 1% of hospitalized COVID-19 patients, there is a possibility of pneumothorax. And pneumothorax associated with the hypotension is called tension pneumothorax, which puts extra pressure over heart, a tamponade effect. And gate vessels also obstructing the venous return, hence called the obstructive shock, which is a life-threatening condition. So answer over here, the correct answer is option A, obstructive shock. Now let's move to the second part of the question. What will you do further? Whether you put a large bore tube tricostomy or chest radiograph stat has to be done, or needle decompression or bag wall mask ventilation. So definitely this is a life-threatening situation causing the hypotension. You have to perform a procedure which is very easy to do in seconds, okay, because there is no time, and also it is not so cumbersome. So needle decompression is the most easy procedure. Anybody can do that, and that is the answer over here. It can be done in a shortest possible time. So this is the correct option. So needle tricostomy is an emergency, potentially life-saving procedure involving the wide bore cannula placement into the second intercostal space in the mid-clavicular line, just above the third rib, avoiding the neurovascular bundle which is running beneath the rib. So you have to avoid it. That's why you have to put a needle just above the third rib in order to decompress a tension pneumothorax as per advanced trauma like support guidelines. Okay, and it is preferred over the tube thoracostomy for the initial management of a tension pneumothorax, certainly. And you can use a wide bore needle because sometimes there may be blood or clot which may obstruct the small bore needle. That's why you have to use the larger bore, about 14 to 16 gauge and about 3 to 5 centimeter, which is commonly available in any ward. Okay, and you have to put just in the second intercostal space, and you will be able to release. You will hear the gush of sound coming out of the chest, and about 1 to 1.5 liter of the air will be evacuated, and the blood pressure and heart rate, everything will be normalized. Now there is a very good prospective multicentric cohort study published in Injury Journal to determine the optimal location for needle chest decompression for tension pneumothorax in about 392 patients which were enrolled in this study, and concluded that overweight and obese patient, the wall is thicker in the intercostal space of 4th, 5th in anterior external line than in intercostal space 2nd mid-clavicular line. And theoretically, the chances of success space in the second intercostal space is higher compared to the fourth or fifth intercostal space, and that is the very good message from this study. Okay, so that is the answer. Sometimes people may ask you in exam. Now, moving to the second question, a 65-year-old man who is admitted to the ICU with acute exacerbation due to pneumonia. The patient required intubation and mechanical ventilation. The ventilator graphics are noticed to have prolongation of the expiratory time of the flow, and sometimes the absence of patient's ventilator triggers despite the patient's movement of chest and abdominal wall muscles to initiate and trigger the next breath. What is the most appropriate next step in managing this patient? Decrease the sedation, increase the respiratory rate, decrease the flow rate, or increase the PEEP level? So this is a very interesting question, because this question asks about the patient ventilator asynchrony, and you have to identify first what type of patient ventilator asynchrony this patient has. Okay, and then what would be the probable management, the best management, appropriate management. So you must remember that there are two most common desynchronies described: ineffective or missed trigger, and extra or double triggering. Ineffective or missed triggers occurs when there is an appropriate trigger setting or intrinsic PEEP despite the presence of respiratory activity. Whereas double triggering or extra triggering occurs when there is an excessive triggering sensitivity or the ventilator cycle offs before the patient's effort ceases. This question, itself says about that this patient has ineffective trigger. Okay, there is absence of enough trigger here. So the type of patient ventilator asynchrony over here is the ineffective triggering or mistriggering or wasted effort, which is the most frequent type of asynchrony in ICU, in the patients who are on mechanical ventilation. As you can see in this figure also, the pressure trigger is not enough to start the inspiration. So can you see over here? So I will highlight with the highlighter. So this is the problem over here, that the trigger is not enough to initiate the breath. This is the most common type of patient ventilator asynchrony. You must remember. Now, what are the common causes? So there are about 7 to 8 causes you must remember. So when you set the threshold of triggering too high, or if you set the tidal volume too high, or if you set the pressure support too high, or if you set the respiratory rate or respiratory time too high. So these are the high situations, okay, where you would definitely get the ineffective triggers. Or if the patient is having some obstruction in the airway due to one or another reasons and develop the auto PEEP or intrinsic PEEP, that can also lead to ineffective triggering, because the tidal volume expired will be lesser. Okay, that may cause the ineffective triggering. And also in case where patient is not able to generate enough respiratory drive because of neurological disorders, okay, or if the patient is having the weak respiratory effort due to neuromuscular dysfunctions, like in patients who are developing myopathies or neuropathy. And it is also described in patients who are on light sedation. The paralysis is not complete. In that situation also, there will be ineffective triggering. Very bad situation. Patient won't be able to generate enough trigger, okay, enough inspiratory effort. So treatment usually involves increasing the sedation to minimize the patient's spontaneous breathing. Okay, and decreasing the tidal volume is also an option, decreasing the respiratory rate and decreasing the respiratory time, which can also improve the respiratory flow, and the problem of ineffective triggering will be gone. Or you manage the intrinsic PEEP by giving some bronchodilator or give the extrinsic PEEP. So how much extrinsic PEEP is required to nullify the intrinsic PEEP. So you have to measure first the intrinsic PEEP, and about 80% of the intrinsic PEEP you have to keep as an extrinsic PEEP to nullify the effect of intrinsic PEEP. So you have to probably increase the PEEP level. So that is the answer to the question, the correct answer. Now in this diagram, can you recognize the missed effort? So this is the diagram which I have taken from Google image, and look at the flow time scalars over here. Flow scalars, okay. And can you look at the ineffective triggering? Yes, so here, okay, here, mistriggering, here. So positive flow deflection in the expiratory phase is the hallmark of mistrigger. You should remember this. Okay, that's all. Thank you so much for your attention. I hope that I will come up with more and more MCQs like this. A good discussion.